Good morning, everyone. Welcome to our end of May installment of the Nursing Health Services Policy and Research Virtual Breakfast. We are really excited to have Dr. Julie Donohue here today from the Graduate School of Public Health. Before I introduce Dr. Donohue, I did want to provide a couple of housekeeping updates. As the summer progresses, we are going to just move to about one virtual health services policy research meeting a month, and those will be at the end of the month. So stay tuned for our upcoming speakers for the months of June, July, and August. We've got some really exciting folks who we've invited to speak the last Tuesday of the month. So mark your calendars, and we'll resume our bi-monthly meetings every 2 weeks in September. So this morning, we're really lucky to have Dr. Donohue here. Dr. Donohue is a professor, vice chair for research, and co-director of the PhD programs in the Department of Health Policy and Management in the Graduate School of Public Health. She's also the director of the Medicaid Research Center and co-director of the Center for Pharmaceutical Policy and Prescribing. She holds secondary appointments in the Clinical and Translational Science Institute and is a faculty affiliate in Pitt's Health Policy Institute. She earned her PhD in health policy from Harvard University and completed subsequent postdoctoral training in pharmaceutical policy research at Harvard Medical School. So Dr. Donohue's research is very policy health services research relevant, and she's actually one of the big things that attracted me to the University of Pittsburgh, the really hands-on research that she's doing in the Graduate School of Public Health that has implications for evolving state policy and national policy. A lot of her research looks at insurance coverage, financing, and the delivery of healthcare with a focus on prescription drugs and behavioral health services. So today, Dr. Donohue is going to be telling us about a new resource that we have at the University of Pittsburgh, Optum, and the implications that that has for research that faculty, students, and postdocs might be engaging in. So, Dr. Donohue, please take it away.
Okay, sounds good. Thanks so much, Haley. Thanks for the opportunity to be here today. Just gonna pull up screens, slides. All right, can everyone see the slide deck?
Perfect.
Okay, great. So, I'm going to be talking to you today about a new data resource that we're pretty excited about. It took approximately 1.5 years to secure. Lots of negotiations across the schools of the health sciences and with Optum in order to make this license agreement happen. And I'm grateful for the support and participation by the School of Nursing faculty and Dean Jacobs. I'm just going to kind of run through some of the data capabilities at a pretty high level, and I'm happy to kind of answer questions based on what I have observed so far. Talk about some of the terms of the license agreement. It's a little different than a typical data use agreement that you might have already in your possession, and then the kind of structure for data access. And feel free to see if I can see the chat function. Yeah, I think you could just shout out questions, because for some reason I'm not seeing chat show up on my my little control panel. So there's a small enough group on the phone here. Don't feel like you need to wait for the end if you've got a clarifying question or comment along the way. Okay, so in terms of the data capabilities, so for health services research and health policy research, Pitt already has quite a lot of data. So various colleagues at the School of Nursing, other schools of the health sciences have Medicare data, Medicaid data, particularly Pennsylvania Medicaid data. And these claims data sets are really valuable in terms of their representativeness in the case of Medicare of the entire US Medicare population, but of course they're payer specific. So they're not going to capture commercially insured enrollees, for example. Many of us have also worked with hospital discharge data from HCUP or from the Pennsylvania Healthcare Cost Containment Council. These have the advantage of being of collecting data from all payers at the hospital level, but of course there's no outpatient data. And for many health services research projects, we need to observe outpatient utilization. It also tends to be better than claims data for, and particularly for PHC4 in terms of having better measures of health risk, at least at hospitalization, but it's not as granular as other clinical data sources. And then we have electronic health record resources from UPMC, maybe from PATH, which is the joining together of, I think now 6 health systems, sort of collective resources that were financed by PCORI in the formation of PCORNet. And these electronic health record databases are detailed but limited in scale, either to a single health system or a handful of health systems. And so if we're interested in studying geographic variation, or if we're interested in, say, a relatively rare condition where we need many health systems in order to get an adequate sample size, these will be limited in many respects. And it's, I think it's important to point out where we are in terms of our history. Now about 90% of all health information is digitized. And so we need to be thinking as a university, how do we harness the power of all of that digital data in the health realm to conduct health services research projects in a number of different areas. Okay, and there's a lot of talk about big data, advanced analytics, machine learning, and incredibly powerful tools from computer science that can make the best use of these large data sets. Okay, so the Optum data that we're licensing as a university are in 2 components. So on one side is the Clinformatics Data Mart, and this is really a large claims data set. And it's claims data from United Healthcare. So it's one carrier, although with multiple different insurance products within that one carrier. So United Healthcare, the data that we're licensing include commercially insured, and that is both employer-based covered lives as well as Medicare Advantage, so the Medicare managed care product that United Healthcare sells. While United does have some Medicaid book of business, that is not included in this particular data set. We are purchasing 2 views of the claims data. One comes with mortality information, a date of death, although not the cause of death. And the date of death is based on multiple different data sources that Optum has accrued over time. A second view includes more detailed information on socioeconomic status of enrollees at the census, I think it's a census tract level. Because Optum is making these data available in a way that you can't identify individuals, you can't have both of these views simultaneously. So one trade-off people have to think about is, are they most interested in death as an outcome, censoring variable, or are the socioeconomic status variables particularly important? Did someone have a question? No, okay. The Clinformatics Data Mart is in fact licensed by many universities around the country. What's relatively unusual and what we were really excited about licensing at University of Pittsburgh is the EHR data from Optum. And the EHR data is from all payers, so it's not just United Healthcare enrollees. It's people with Medicaid, Medicare, other private insurance, and people who are uninsured who visit one of dozens and dozens of health systems around the country. The integrated SMART file is the overlap between the Clinformatics Data Mart and the EHR. So for a subset of enrollees, and a very large subset at that, we have both the claims data and the EHR data. And this is really, I think, a powerful resource and something that is going to dramatically improve on the limitations of using either claims or EHR alone. Okay.
Dr. Donohue, this is Haley.
Hi, Haley. What's up?
I have a question about where the socioeconomic status data come from for the Clinformatics Data Mart. Are those kind of like attributed to the patient's zip code, or are they more individual level? Are they actually linking maybe like credit reports on individuals?
Yeah, they are area level measures from the census. So it's more granular, and I apologize, I can't remember, it's been a long weekend, whether it's at the census block or census tract level, but it's more granular than zip code.
Gotcha, okay, thank you.
Yeah, so we don't have individual level information on socioeconomic status. That is incredibly rare, if not unheard of, in administrative data. Typically you would have to survey enrollees in order to get that detailed level.
I know that some insurers are actually starting to buy information from like creditors to gain more insight into their beneficiaries. I wasn't sure if that's something that we were looking at.
No, we don't have that level of information available. And that's something that health insurers may make available. It'd be great if they would make it available to researchers, but I'm not aware that Optum is considering that. Great. Okay. So just to kind of show you a little schematic that Optum provided to give you a sense of all of the different information that's available from the merger of these two data sets in particular. So you have detailed information on medications, and there's several sources of information. So on the electronic health record side, you can observe prescription orders, both on the outpatient and inpatient side. For the inpatient side, you can observe medications administered to patients in hospital settings. And then you also observe the patient-reported medication or medication history with all of the limitations that go along with patient-reported information on medications. We know that is not always the medication reconciliation system has some limitations, and we know that information is not always updated, but you have all three sources of information: medications, prescriptions written, administered, and then reported by the patient. In addition to that, on the claims data side, you would have all of the pharmacy claims. So every time a patient went to the pharmacy to fill a prescription, you would observe that. So there's really, really rich information on prescribed medications from the claims data and the EHR data, and particularly the linked data set. There's also the ability, because you have claims data, to construct very detailed measures of cost, whether you're talking about the disease burden, the out-of-pocket burden associated with healthcare utilization, or from the health system's perspective, how much is being spent on a particular patient or patient cohort over time. From both the EHR and claims data side, you would have a record of all procedures based on procedure code that were completed for a particular patient, the indications for those procedures, and comorbidities from all diagnosis codes, again, available both from EHR and from claims data. There is pretty detailed information on provider specialty available in the data, and demographic information on patients, including age, gender, and race ethnicity, although, as is common in many administrative data sets like this, race is missing about a fifth of the time in both data sets. So that's one limitation to be aware of. Lab values. So you have lab values from a couple of sources. So certainly the EHR data contain lab values for every lab you can imagine being ordered for a particular patient. There is also lab value data, not just labs ordered, but the values for a subset of those in the claims data. Although Optum has told us that it's incomplete for about 2/3 of enrollees, and if you're interested in lab values as an outcome or covariate, the EHR data is really the way to go. From the EHR data, you have vital signs, a variety of vital signs, and then finally, the provider notes. So we do not have the unstructured notes fields, but what we do have is a variety of structured variables that Optum has derived from the unstructured notes using natural language processing. So they've taken a lot of information that would be in notes and sort of difficult to use on a large scale, and created these derived variables for us to use. And one thing to note here, the academic business for Optum is a pretty small part of its portfolio. These data sets were really created in order to serve the pharmaceutical sector, the medical device sector. And so, this is the kind of information that is useful for product development. So for example, for the pharmaceutical industry, they've created a whole host of variables that try to get at, why prescribers change someone from one medication to another. So you might have information on side effects or other information that led to that medication switch. And so we can, as academics, take advantage of the fact that these variables have been created. So I'll just pause there and see if you have any questions about the kind of high-level data capabilities.
Hi, Dr. Donohue. This is Stephanie Hellman. I do have a question about the age of these individuals that are being included. So my research focuses on pediatric patients. Mm-hmm. So does Optum include patients under the age of 18?
It certainly does.
Okay.
Yeah, good question. So employer-based health insurance, commercial insurance will include the employee who's covered, as well as all of his or her dependents. So children, spouses are included, and we are conducting research right now on pediatric populations using the Optum data. So that's on the claims side. And on the EHR side, it is everyone from birth to death. Every age range is included.
Okay, thank you. That's good to know.
Any other questions? Okay. So I'm just going to give you a sense of the scale of the data. in terms of, if you're interested in a really rare disease, for example, this will be a great data set for you to use because it's a staggering amount of data. It also goes quite far back in time. So we have 13 years of data already in our possession. So calendar year 2007 through 2019, and we'll be receiving annual updates every January. So in January of 2021, we'll receive what will be the second 2 quarters of 2019 and the first 2 quarters of 2020. There's about a 6-month lag. So it's pretty timely relative to data that you would license or secure from Medicare, which might have a 2-year lag at best. All told, there's about 13 terabytes of data. So it's massive, not something that you can store on your own personal computer. It requires quite a sophisticated computing infrastructure in order to use the data. It's huge. In terms of the covered lives, we have 63 million people in the claims data. So again, this is commercially insured and Medicare Advantage. And the data that they license is based on folks who have at least 1 medical claim and at least 1 prescription drug claim. So that's the subset. On the EHR side, we have 103 million unique patients that we can follow over time. Now, some people may only be observed once, and some people may be observed over a period of years. And Optum has created derived variables to help us capture who might be covered by these EHR data sets. EHR data, as you might be aware, don't have dates of enrollment in the same way that claims data do, where we know, okay, this person is covered by Medicare from this date to this date, and so we should observe all of the healthcare utilization, or at least the vast majority of it that Medicare pays for. On the EHR data side, we have to make some assumptions about whether we're observing that individual and able to follow them over time. And those, some of those derived variables have been very helpful on the EHR side. So in all, 150,000 providers, including nurse practitioners, physicians, providers of all specialties are included in the data. 2,000 hospitals and 7,000 clinics. So if you're interested in looking at variation in healthcare utilization or outcomes across healthcare organizations, this is a really rich data source for you to use. And then one final note about the overlap between claims and EHR, that includes about 20 million unique people over the several year period. So it's still a large sample size that has the intersection of those two files. Okay. So I'm going to move now to talking about the terms of the license agreement, unless there are questions on the data capabilities. Okay, so the license agreement is unusual because it is a license agreement that covers all schools of the health sciences. So usually when researchers license data, they're licensing it for a limited set of individuals and for a limited purpose. In this case, we're licensing it for basically the entire, all schools of the health sciences, and for any research project that individuals in those health sciences schools might envision. So it's not specific to a particular project. And because it's being used in so many broad and varied ways, there are relatively strict terms included in the license agreement. So I'll just walk through what some of those are. So authorized users, personnel within the schools of the health sciences, so quite broad. This could be students, staff, and faculty. So anyone with an affiliation and the details are spelled out in the license agreement. Anyone with an affiliation with one of the schools of the health sciences is entitled to use it. And it could be for any research project. And again, because Optum has, a whole other set of clients or customers on the industry side, they want to make sure that we're not using it for commercial purposes, that we're really using it for research, not as a kind of pass-through to a pharmaceutical company. All users of Optum Data have to be trained and sign an acknowledgement of the license agreement that they've been updated on the key terms. And that's a relatively simple, straightforward training that we've developed. Optum has the right to review academic products for accuracy of product name and the absence of confidential information. And the scope of the review is spelled out in the agreement. They're not offering scientific feedback at all. They really just want to make sure that we are referencing the products appropriately and that we're not divulging individual row level data. And then there are lots of security requirements. So for example, we have to keep track of who has access to the data at all times, firewall and password protection, and several other requirements. And when we looked at the security requirements, we determined that really the only game in town, the only environment on campus that could meet these requirements was the Health Services Research Data Center. And I'll talk a little bit more about that later on. Okay, so because we licensed this, first of all, we've collectively financed this data purchase, which is over $600,000 for the next 3 years. It was a big ticket item. It was not something that any one of us, any one school could pull off. All the schools of the health sciences contributed financially to this collective resource. We wanted to make sure that we were providing appropriate oversight and organization to kind of make sure that this resource was widely known and available. So we're doing presentations like the one we're having this morning to other research groups around campus, and making sure that there are contacts within each of the health sciences schools that people can go to with questions. So I'm just going to talk a little bit about kind of oversight and organization. So data access is centralized and monitored, as I said, in the Health Services Research Data Center. There are 2 training requirements. So one is on how to use the HSRDC in general. And it's basically training on best practices in data security, and then also on the sort of technical aspects of using the virtual desktops on the HSRDC. And then we also have a brief training on the license agreement just to make sure people are using the data appropriately. We have a health sciences-wide executive committee that provides oversight. So if we have to make kind of policy decisions for use of the data, we have that governing body. And just for your information, Grant Martzoff is the School of Nursing representative on that executive committee. We also have a super user group, and this is to kind of put in place for a couple of reasons. This is a really rich but very complicated data set. It's not something that, if you've never used claims data or EHR data, that you'd want to jump in with and try to extract something useful in a 1 or 2 month time period. It's complicated. Even for those of us who've used these big administrative data sets, it's complicated. And so we're trying to use this super user group, which is a group of about 8 or 10 people who have substantial expertise in electronic health records and or claims data analysis, to try to create even more detailed documentation on how to use the data so that we can lower the barriers of entry for people who are new to this kind of data resource, and make it more usable. So this is a group that would be great to kind of stay connected to. And they're also the group that is kind of funneling questions back to Optum so we don't overwhelm Optum with 60 people from the university reaching out with specific questions. We're trying to centralize that process a little bit. And then, because, sorry, my dog is going crazy. Hang on just a second. Sorry, I'm back. Joys of working from home. Okay, so because Optum has this requirement that academic products be reviewed, we will handle that process in the Department of Health Policy and Management in the Graduate School of Public Health. Again, just to kind of centralize the process a bit. The other thing I'll note here, and this is not a requirement of the license agreement, but something that is really important for making this investment sustainable long-term. If you submit a grant using the Optum data, please let us know. And we're really just interested in, what's the title of the grant and what agency are you submitting to? At some point, we would like to make this a more centralized investment rather than going to lots of individual schools and investigators. And we're interested in building the business case for that centralized investment. So we need to keep track of how many grants are coming in because of the availability of this data resource.
This is Haley. I have a question about the super user group. So I know this is something that came up at the training back in February, and efforts at kind of making code and approaches more a community resource. What are some plans you have right now and some efforts to help the super user group communicate with people who are using the data?
Yeah, so it's a really good question, and I can't say that we have it all figured out in terms of the communication side. What you've said is right, Haley, that we're trying to create code that could be used across research groups. So, for example, we can generate code for the Optum data to create Elix-Hauser comorbidity or other comorbidity indices that are widely used. Right now, we're trying to create an index to the data to make queries faster because the data are so massive. If someone is building a cohort, we want to cut down on the computing or processing time it takes to query, billions of records. So that's the kind of thing that we're focused on right now. And we have, we're kind of coming to near to the end of this a sort of 6-month startup phase in use of the data. And now we're going to start trying to make some of these resources more available. Because data access is centralized with HSRDC, we have email addresses for everybody with access, and we can send out periodic updates. The HSRDC lends itself really well to developing shared resources that every research group could access. So if you create sample code for identifying people with emergency department visits, you can share that pretty easily using that platform. And I think what we're trying to figure out right now is how best to organize research groups around similar topics. So are there disease-specific interest groups or groups that are working in a particular setting, for example, largely working with inpatient hospital records that might be organized around those topics so that we can develop shared resources that go along with the data, if that makes sense. So I think short answer is it's a work in progress. And I'll keep you posted. And I am very eager to hear ideas that you have. This is a different way of working together across a large number of research groups and a large number of schools. And so I think we're open to ideas on how best to organize ourselves.
Great, thank you.
Great. So finally, I want to talk a little bit about how data access works. So as I mentioned, the data reside on the Health Services Research Data Center. This is a secure, collaborative, high throughput computing environment via virtual desktop. So you can be anywhere in the world and access data and conduct analyses on the Health Services Research Data Center. It's I think the only computing environment on campus that is both HIPAA compliant and FISMA compliant. So it meets a very high standard of data security and privacy. Provides security, access controls, and an interoperable interface. And it can support many, many different kinds of software. So, we use SAS, R, Stata, and several other softwares on the HSRDC. So as I mentioned, we're kind of coming near to the end of our short-term data access plan. So when we started data delivery in January, and for the first 6 months, we wanted to make the data freely available to anyone who was interested in this kind of startup phase. So faculty member from CCM and I have subsidized this initial desktop that people can access through the end of the fiscal year. And we nicknamed it Optum Advanced Testing Evaluation Scouts, or OATS. So that's where most people are accessing the data right now. But long-term, we will be asking schools, departments, or groups of investigators to pay for the HSRDC, which is a cost center at the university. It's not something that is being invested in by the university. It's something that's supported by users. So even before the Optum data, I was using the HSRDC to house Medicaid data, Medicare data, and other data sources for research. So the long-term data access plan is for investigators to access Optum through individual desktops. And these can vary in size from 20 users to 2 users. And it really just depends on the need and how it makes sense for each individual research group or school or department to organize itself. And it really does depend on the scope of the research project, the team that's involved, and the number of people who need to access the data. But I'll just say it's incredibly flexible on the HSRDC side, how many people have access to each virtual desktop. And I'm not doing the HSRDC justice. We have staff who would be happy to give a much more detailed presentation on the HSRDC and its capabilities, but I wanted to just give at least a high-level overview so you have a sense of where to start. So the way that the HSRDC fee works, it's based on 2 components. One is data storage, and that's based on the gigabyte. And then the second is the kind of number of users you have per desktop, again, with that flexibility to have as many or as few concurrent users of the data as your research project requires. Because these data are so large, we're trying to get that fee for storage down to as low a level as possible. And so we can, we're imagining that we might provide data management support to create smaller analytic files, so you don't have to pay for storing the entire 13 terabytes if you only need a tiny fraction of that to do your research project.